Hello, my name is Dr. Rico Short. I am a diplomate of the American Board of Endodontics and also a assistant clinical professor at the Medical College of Georgia School of Dentistry. I'm going to be speaking to you about endodontic retreatments and why we do retreatments, and in a sense, how do we do retreatments? This is a disclosure statement. In compliance with the American Academy of Family Physicians AAFP guidelines, I hereby declare I do not have financial or other relationships with the manufacturers of any commercial services discussed in this educational activity. Also, this information presented in this presentation is designed for educational purposes only. The reproduction and/or selling this material is unauthorized unless approved by Dr. Rico D. Short and/or the American Association of Endodontists. I can be reached at dr.short@yahoo.com or the www.aae.org, which is the American Association of Endodontists. The name of my practice is called Apex Endodontics PC. I'm located at 577 Concord Road, Suite A, Smyrna, Georgia 30082. Phone number 678-503-0790. And my website is www.apexendodontics.net. If you have any questions or any issues, even on the root canals that you've treated, feel free to use my very user-friendly website, very interactive, and you can also contact me, send me radiographs of cases you've treated, and I will get back with you and try to help you out. So what are the objectives we want to cover today talking about endodontic retreatment? The first objective is we want to discuss some reasons for endodontic failure. Why do root canals fail? Or do root canals really fail or patients fail to heal? So we're going to be talking about that. Also, the success rate of retreatment versus implants. We know implants right now is a very hot topic. Most of every dentist know about implants, and most dental companies believe, in my opinion, that any dentist can do implants and do them well. So we're going to be talking about that. Also, we're going to talk about retreatment strategies and techniques, including success rates on retreatments as well. Shimon Friedman, he made a very interesting comment in 2002. He said, when you're discussing root canal failure with patients, don't call it your root canal fail. Ms. Jones, your root canal fail. We call it post-treatment disease. This takes some of the negative connotations off root canals. Right now, how many people you know that looks forward to getting a root canal? Probably not many, because of all the horror stories and experiences they had, and some of them likely so. However, when we call this thing post-treatment disease, it really gets into a little bit more of the nuts and bolts, and it talks about, hey, did this root canal really fail, or did this patient fail to heal, or did we really have any control over it? So post-treatment disease, I encourage you to use that statement versus your root canal fail. What are some of the etiological factors of post-treatment disease? Persistent or reintroduced intraradicular microorganisms such as Enterococcus faecalis and Candida albicans. Extraradicular infections, infections on the outside of the root. Actinomyces israeli, and also bacterial plaques. We have to consider these as etiological factors that cause post-treatment disease. Again, let's use post-treatment disease versus root canal failure. Foreign body reactions, lentil beans, cellulose, fibers, true cysts, self-sustaining, and those won't heal after endo. And for more information, you can look in the Essential Odontology 1998 by Sundquist, and there's more information regarding on some of these etiological factors. Did you know there are up to 40 million endodontic cases are treated annually, and about 75% of them are performed by the general dentist? Let's talk about some of the success rates. Orthograde endodontic treatment. And orthograde is basically a big word for an initial root canal treatment. No retreatment, no surgery. It runs about 90 to 95%. Studies by Karikis, Schwartz, Skidmore, and some others actually shown that. Retreatments run about 80 to 93%, which is where we're going to focus most of our attention on today. The Toronto study, Allen, Bergenholtz, they also verified that in their research. And surgery or apicoectomies runs about 40 to 78%. However, you do have some clinicians claim they can get up to 99, 100%. I'm not really sure about those high levels of success with surgery, but that's what they're claiming. But on average, 40 to 78%. Toronto study, Allen and Nunderman also confirmed that as well. And also Kim, which is one of the ones that boasts that he has very high success rates, up at 90 to close to 100%. So why do root canals fail? Let's look at some of these reasons on why root canals fail or post-treatment disease. You can look at this radiograph here. It doesn't take a rocket science to figure out you have a lot of issues going on with this premolar. So let's look at this. Look at some common causes of failure in this case. Leaky restorations. You can see this margin here. Leaking bacteria going down here and reinfecting this tooth. Root fractures. There's a high chance that the root on this tooth is fractured. Untreated canals. You can have multi-rooted teeth, and if you don't treat all the canals, it can definitely lead to failure. Inadequately clean canals. Canals that were not cleaned and shaped properly. Operative errors. Iatrogenic errors. You're not in the long axis of the tooth. You perforate the tooth. Those can cause failures as well. When should retreatment be considered? Let's think about this. When should we consider doing retreatment versus extraction or versus surgery? We need to evaluate the periodontal status. How do we do that? We can take periapical x-rays, also bite wings. We check the attachment. We look at the attachment. We do period probing. We look at the mobility and the crown root ratio. All of these are very important into even diagnosis and also prognosis of the tooth if you're considering retreating it. We need to also evaluate the tooth restorability. Can the tooth be restored? Let's look at the periodontal support. What is the strategic value of the tooth? If we retreat this tooth, what's the strategic value? Will this tooth hold a bridge? Will it be able to hold an implant? Excuse me, not an implant. Will it be able to hold a crown? And that crown may be attached to a partial. And what about the remaining tooth structure? Do we have enough tooth structure to build up? Is there enough tooth structure to place a furrow so you can get an adequate crown on the tooth? But consider the impact of retreatment. If you don't have to take that tooth out and you can retreat it, patients are very, very, very excited about that. However, before we jump to conclusions, we want to assess the patient concerns. What are the expectations? Are they motivated? If the retreatment is done, are they motivated to go back and get it restored, to get a new crown? Cost, can they afford it? Let's talk about cost of retreatment and also the restoration. Sometimes a crown may have to be redone. Sometimes it can be restored with an amalgam or a composite. So we gotta assess costs. Communication is the key. This is one of the #1 things that I recommend most or all dentists, especially endodontists, to make sure they communicate, because patients want to know how successful is this? Or some patients may want to know, is it 100% successful? And I tell them, hey, you know what? It's nothing 100% but death and taxes. I know people throw that phrase around, but especially with retreatments, because sometimes we get in these cases we don't know what's in there, kind of like a box of chocolates. You go in there, you think it's one thing and it's something else. So you want to make sure you do an accurate diagnosis, give them a prognosis, whether it's favorable, guarded, or unfavorable, meaning surgery or extraction. And you also want to give them treatment options. What if they can't save the tooth? What are some things that you can do if you can't save the tooth? And the reason why you give this information so that they can make an informed decision. We never want to push treatment on a patient. We want to also give them an informed decision, because at the end of the day, if it doesn't work out and that patient knows you have been very honest with them, they will still come back, give you business, and they will still have trust in you and also their dentist and other dentists to work on. So let's look at retreatment versus surgical intervention versus extraction. A retreatment, in my opinion, that's the best option. Best option, hands down, if you can do it. And it reduces the need for surgery. In fact, if you have to go back in and do surgery, it actually improves the surgical prognosis. So retreatment, if you've had a root canal, that's the #1 option versus jumping and doing a surgery or taking the tooth out. And most of the literature will validate that. However, sometimes we do have to do endodontic surgery. This is me actually in a clinic in Mexico teaching some other dentists and also dental students how we do apical surgery with the microscope in the United States. Why do we have to do surgery sometimes? Calcified canals, procedure errors, posts, can't get the post out, can't get around it, root fractures, and also root anomalies, severely curved root, dilacerated roots, and we can't take care of it from a orthograde standpoint. You can do all that, and sometimes extractions are inevitable. The tooth can be non-restorable, a guarded periodontal prognosis, split tooth, crack in the root, vertical root fracture, and sometimes the tooth will have to be extracted. Here it is, tooth number 30. We have a crown on the tooth, we have a post here, and a previous root canal. And you can see right here at the end of the root here, there's an area of infection. So this patient really wanted to save the tooth. So I said, okay, well, let's try to retreat it. But there are some obstacles with this. So we went over everything. We got the patient to sign the informed consent. And so we went in there and we said, hey, we possibly can fix this, because you can see here, looks like they may be about 2 or 3 millimeters short of the apex, maybe some tissue here. That's probably why this thing is failing. So let's jump in. So we jump in the case at 2 posts. We take those posts out. We get all the way down to the end of the root. Possibly this has an early exit. We have a puff of calcium hydroxide, which is medication we put in the tooth right into the area of infection. I feel great. I said, man, this thing is going to work. We retreat the tooth. We seal everything all the way down to the apex. Perfect. Looks textbook. So let's see what happens. 2 years later, the patient comes back. Some buccal swelling here. So we decided just to lay a flap to see what's going on with that beautiful root canal. This thing can't be failing. And lo and behold, there's a vertical crack right in the root. No significant probing, but there's a vertical crack here with quite a bit of loss of bone here. So the tooth had to be extracted, even in my hands. So, it does happen. It does happen. So what are the patient options after extraction? You pull the tooth. What are some of the options they have? Nothing. Sometimes patients don't have to do anything. We encourage them to do something. We encourage them to get some type of restoration, but they don't have to. They can get a partial, they can get a bridge, they can get an implant supported prosthesis. Implants. Let's talk about implants. Who's the best for the job? Periodontist? The oral surgeon? What about the general practitioner? the GPs, the general dentist, the prosthodontist, the endodontist. Did you know, and there are some residencies now that they are training the endodontist to extract the tooth and also to put the implant in the area as well. My personal opinion on that, I think that endodontist, we first of all, if you are a dentist, you are smart. You can do just about anything. However, the way you become very well at doing something is doing it over and over and over and over again. And if you don't do implants every single day or as often as you should do them, there's no way you're going to be at the same level of someone else who does those every day. So in my opinion, if that's not what you do every day, if you're not properly trained on those, I think you're asking for problems. So are you smart enough to do those as a dentist, as an endodontist, as a prosthodontist? Sure you are. But should you be doing that? And if it was you, would you want someone to practice implants on you, or would you want to go to someone who does do these every day, who are properly trained to do that? So I don't think you need me to help you answer that question. This is the case. A patient came to me to look at a tooth, and she said, you know what, while you're in there, can you look at my implant? I said, sure. So the surgeon actually malaligned this implant, and you can see where it is. So she was saying that she felt something metal rubbing against her cheek, and I saw that, and I asked her nicely that if she can go back to the person who did and ask them to reevaluate the implant. So let's talk a little bit more about implants. So the survival rate is actually equal to endodontic treatment. So the survival rate for a single tooth implant is just as equal to initial orthograde endodontic treatment. And that was verified by Dole and the JOE in 2006, and also by Iqbal in the International Journal of Oral Maxillofacial Implants. However, there are some complications with implants that most of the manufacturers may not even talk about. Hemorrhage is one, neurosensory disturbances, adjacent tooth devitalization, mandibular fracture, air emboli, which is serious and sometimes can be fatal. Doyer in 1992 actually had a case report of that. Bisphosphonate patients, osseointegrating into the bone, implant abutment screw loosening. And so Goodacre from Loma Linda talked about some of these complications with implants. So I'm not saying implants are not good. I think implants are great. They're phenomenal. As long as the original tooth can't be salvaged, I think implants are great. So I get a phone call and they say, hey doc, I need some help. I broke a file off and I could not get to length. So here it is. This is an x-ray on this upper first premolar here, showing that's the crown, root canal filling material. We got some amalgam or something in here, separated file, and possible perforation, inadequate obturation, and a small access through the crown. So thankfully I use microscopes for all of my cases, especially retreatments, because you cannot treat what you can't see. So I use microscopes. Without microscopes, I don't think we'll be able to have a success rate nearly as high as we have it with the retreatments. So the question is, where do we start? We have to look at how much time we have managed with this issue versus other patients we have to treat. Look at the patient motivation. I mean, are they willing to go forward with this treatment? Are they willing to get the tooth restored in a proper manner once it's completed? Let's look at the case complexity, especially for you as a general dentist. If you're looking at this, how properly trained are you to take care of this case in a very efficient manner? Let's look at the cost, because typically the cost of retreatments will usually be more than initial root canal, because you have to go in and basically disassemble things, which is going to cost you more time, materials to use, which is going to cost basically more overhead. So that costs have to be reflected in the price of more expensive with the retreatment. So where do we start? So here's a pre-op. So basically what we did, we opened the tooth up. We actually, with the microscope, removed the separated instrument. We got down to length, and we also, there was a perforation in the furcation area. We repaired it with MTA. That's the post-op. So we were able to save this tooth for the patient. You asked me, what armamentarium do you need for optimal success? Proper training and expertise, just like I mentioned before. An apex locator will help tremendously. Solvents, microsurgical instruments, digital radiographs, proper intracanal medication and repair material such as MTA or calcium hydroxide, a surgical microscope. Patience. It takes a lot of patience. That's one reason I think that a lot of endodontists don't do retreatments. They want to jump into surgery because these are the most technical, and sometimes it takes a long time to get through these calcified canals to get these instruments out. And if you're not properly trained, it can be very frustrating. And I can understand the logic behind just jumping in there, pulling the gum back, chopping some root off, put some material in there, and close it up. The problem is it's still in the tooth. So if you get leakage or you get bacteria to come through a lateral canal, or the seal breaks with the retrofill material, you're back to square one. If you do the retreatment first, you go in there, you get the source of the problem. If there's still a problem, you can always come back to do a surgery. If you come back to do a surgery, all the research shows that your surgical success rate will be higher following a retreatment. Sometimes the restorations have to be removed, crowns and bridges. We have to identify the problem. Then we got to figure out how are we going to remove this crown or go through this bridge or go through this crown. We're going to talk about some new technologies, and sometimes it's not always feasible. Some of those cases you may have to do surgery if the patient don't want you to go through their brand new crown or bridge or what have you. We got to consider the post removal. How long is the post? Because the longer the post, usually it's going to take you a longer time to actually remove it. The diameter, how wide is it? Sometimes the post is too wide. By the time you use your ultrasonics and get around it, it can actually crack the root or weaken the root enough that it just cracks on its own. What about the direction of the post? How is the post the long axis of the tooth? Is it off to the side? Let's get some cementing agents. So some of the cementing agents can make it very difficult to remove the post as well, and also the design. Talk about parallel-sided post versus screw post. Let's talk about removing obturation materials like gutta-percha, silver points, carrier-based obturators, and paste. We're going to actually go through each one of these, and I'm going to share with you how I remove those obstacles in the tooth. Removing gutta-percha first. Do you guys know what this is here? Think about it. It's a gutta-percha tree. No, not really. It's actually called a Tabin tree, which is what gutta-percha is made from. They take extracts, it's like a cousin of a rubber tree. They take extracts from the juice of the tree, and they actually produce gutta-percha. Did you also know gutta-percha is actually in the center of golf balls? So the next time you're playing golf, make sure you let your partner know that if they hit that golf ball too hard, gutta-percha may come out. No, I'm just kidding. It won't come out. But it is in the center of the golf ball. So I thought that was some pretty good trivia for you. So how do we remove gutta-percha? We use rotary instruments. We also can use heat. We use ultrasonic solvents, and sometimes we have to use a combination of these, especially if it's old gutta-percha. I'll call it stale gutta-percha. It's very hard to remove. You may have to use a combination of these things in order to get it out and get down to the apex of the tooth. Removing silver points. You have to be very careful when you're removing these silver points. Silver points, if you basically cut off the tip of the root, the tip of the silver point, and you can't grasp it with something, you are already in trouble. So if you see a case and you want to try to retreat it, when you access the tooth, make sure you do not hit those silver points, because if you hit those silver points and they break off below the cavo surface of the tooth into the pulp chamber, or into the canal orifice rather, you're going to have a hard time removing it. If you can actually expose some of the head and you get some irrigants around it, some solvents, and you have a better chance in removing these. So you need magnification and illumination, a lot of light so you can see it, ultrasonics, solvents, pliers or micro forceps, some people call them stiglets, and the combination of these can help you remove those silver points. And these are 4 silver points that were removed from a tooth that I've treated. And here it is, case in point. Tooth number 19, the general practitioner and the periodontist wanted to extract and place an implant. The patient really wanted to save this tooth. So I talked to the patient and said, hey, you know, we have a shot to save the tooth. What did I say our success rate was? Success rate probably runs about 80 to 85% from retreatment, and the patient decided to go for it. So we actually isolated it, took out the silver points, put calcium hydroxide in for about 3 to 4 weeks, brought the patient back, we obturated, got a nice result there. And this is a before and after 5-year recall showing that the patient did get the tooth restored, and the area, we can see there's some nice healing with that, and the patient was very happy. They decided to retreat the tooth regardless of what the general dentist and the periodontist was saying, is probably to take the tooth out. So what I'm saying is just make sure you give the patient all the information so they can make an informed decision. Send the patient to the endodontist if you're not sure if the tooth can be salvaged with the retreatment. Removing carrier-based obturators, THERMOFILLS. These can be very, very difficult, especially if they're around a curve. What do you need to remove them? Magnification, illumination, ultrasonics, heat, rotary instruments, solvents, micro forceps. Almost kind of like the same thing you would need to remove gutta-percha. However, a lot of these THERMOFILLS, they have that plastic core that makes it very, very, very difficult to remove, especially if it's around a curve. And I actually retreat THERMOFILLS the most. And the main reason is usually not because of the THERMOFILL itself. It's usually because these cases are usually inadequately cleaned and shaped. They look great on the x-ray, but there's tissue and bacteria still in the canal space that usually cause these things to fail. So this is a case here on a lower molar that we treated. On the x-ray it looks great. They even got a puff here. We took the material out. We placed calcium hydroxide here, finished the case, and 1-year recall showed nice healing. So that's THERMOFILL retreatment there. Removing paste. No, I'm not talking about toothpaste. They're pastes that are used mostly in Europe and overseas. There was a paste here that is no longer available called Sargenti, and they found out that Sargenti can have this formaldehyde component in there that can cause paralysis, even can cause cancer, so you can't even buy this paste anymore in the United States. But there are some pastes that get very hard, like a resin that's still sometimes used overseas, Europe, China, places like that. You need magnification, illumination, ultrasonic, solvents, any combination of these. Solvents such as chloroform will definitely help you with some of these cases. So this is one of those paste cases that I saw. This guy was out of Europe. You can see that the crown and the restoration doesn't look the greatest. So he wanted to still try to save the tooth, so we took the tooth apart. We obturated the case. We had to place MTA in the furcation. There was a furcal defect with decay there to repair that. Unfortunately, I didn't get the patient back. Couldn't get him back to do a recall because he went back to Europe, and hopefully he still has the tooth and got it restored. Other considerations with retreatments: flare-ups. Sometimes you can have these cases that can flare up on you. You have an old case, particularly with silver points. By the time you take it out, the silver points, salts, and the debris can get pushed out into the apical area, It can cause a flare-up, swelling. How do you manage that? One of the main ways I'm able to manage that flare-up and swelling is using a Medrol dose pack, which is a very low dose steroid that really helps very well. And also to these patients, it's very important for them to get a final restoration on these cases because they can leak if not. And also you want to get them back for recalls, because if the area isn't healing, you may be concerned that you may have a non-odontogenic issue going on, cancer, tumor, cyst, or something like that. I like to get patients back 1 month, 6 months, a year recalls if there's a lesion present. So this patient came in, Dr. Short, my front teeth hurt and I have a bump on my gum. And his history was that he had the root canals done a while ago, probably over 10 years ago. He went to an oral surgeon. The oral surgeon opened it up, cleaned it out, and he said these bumps still come back and it's very sore. So I want to know what is going on and what do I need to do. So we took his medical history, his dental history, and we told him, hey, you know what? We can try to retreat this tooth, and we can't make you any promises, but we'll see if we can fix this tooth just by retreating it. So he agreed. So what would you do if this was your case? If this was you or your patient, would you retreat? Would you encourage an apical, or would you just extract the tooth and do an implant? So I give you a few seconds to think about that. Number 8 and number 9, what would you do? I'm going to tell you what I did. We're going to attempt the retreatment, of course. So if you have an area that's draining, it's very important. It has a sinus tract to trace the sinus tract. Sometimes you even have to numb the patient up. Sometimes you don't, but sometimes you do. It's very important to trace it. Why? Because when you trace where the sinus tract is coming from, it also can let you know where some of the main etiology is, so where you can focus on trying to fix it. So this is a case in which he had a sinus tract on teeth 8 and 9, and you see kind of direction where it is, they are actually going towards around where that post is. So kind of lets me know, you know what, this case may be perforated. So this case we did a 1-visit retreatment with MTA, which is mineral trioxide aggregate, which is our miracle material in endodontics. And basically it's a Portland cement. It gets very hard and it is very osteogenic. The bone loves this stuff. So we use it for different things. In this case we use it as a repair material to seal off the perforation. So you can see here, kind of like see a little bit where the perforation was. So this was retreated, and look at this, the endo, I didn't get all the way down to the end of the root, and that did concern me, I'm gonna be honest with you, but I didn't want to keep going and opening this tooth up more and do more damage, cause more leakage. So I said we'll monitor and we'll see what happens. So here it is, we worked on tooth number 8. Number 9 ended up needing the same treatment, but this is a 6-month recall on number 8, and this is an off-angle view, so you can see the MTA actually going right up to the ligament here, sealing that perforation area, and this is gutta-percha here. So this is the 1-year recall, and also we retreated number 9. It also had a perforation as well with MTA. Sinus tract resolved, and this is the before and after, teeth number 8 and 9. So huge area. This is with no surgery. This is taking care of that area with MTA. Beautiful. So another case, we had a medically compromised patient who had HIV on tooth number 30. You can see here we have a crown here, previous root canal, filling material very weak, he couldn't get around the curve. He has areas here, huge screw posts. So if this walked in your office, what would you do? Would you do surgery on the tooth? If you are considering surgery, you want to take note that this patient is HIV positive, so you have to make sure you have a very sterile area and make sure you manage him as well from a medical standpoint. Should you extract the tooth? Should you retreat the tooth? Or are you concerned that it's a crack due to a large post? Think of what would you do if this was your patient. Think about it. Well, I'm going to let you know what we do. We explain everything to the patient once again, and he decided to have the tooth retreated. So we took the tooth apart, we placed calcium hydroxide in here, and the best we could, and we brought the patient back and we obturated with gutta-percha. This is no MTA, this is a strictly gutta-percha here. So this is before and after 1 year recall. Amazing, amazing healing, textbook healing. And this is just phenomenal. This is with no antibiotics, and after 1 year with HIV, showing that this area healed up. He got the tooth restored, and if I'm not mistaken, this is the same crown. So let's look at tooth number 19. This is another silver point here, retreatment. So again, when you have these silver points, you can see the head is exposed here. So when you access, do not cut that head off below that the pulpal floor, because if you do, it's going to be very difficult to get these things out. So once we accessed it, we were able to take the silver points out. We were able to place calcium hydroxide in all the canals. We were able to close it up. We brought the patient back, I think in 2 to 3 weeks. And before we show you the final, just remember, every case is unique. It may look like it's something routine until you get in there. And that's why people who are not endodontists say, well, Dr. Short, how in the world can you do root canals all day? You're not bored? It's the same thing over. You know, my friend, let me tell you, it's never the same thing over and over again. It's always different. Every tooth, every patient is always different. Now, yes, you have to use some of the same techniques and procedures, but it's always different. So I don't take it for granted, and I really love being an endodontist because every case is truly unique. Just like this butterfly with transparent wings, very, very, very unique. So we completed the case, and look at here, this thing had a snake tongue split right at the apical third. Amazing. So this is before and after. So one reason why this distal didn't heal is because there was another canal right in the apical third that had a branch in there. Okay, this is another premolar here we had. Well, not another premolar. This is the first premolar I believe we had. And you can see this is a huge silver point. This was done a long time ago with a big area of infection there. And the patient still wanted to keep the tooth. So I went through all the options with the patient, and I said, hey, let's try to see if we can salvage this case. So we took it apart. We placed some calcium hydroxide in here, the medication, for a couple of weeks. We brought the patient back, and we obturated with MTA. There was a small crack there, but we used MTA, and we said we'll see how the patient's gonna heal. We brought the patient back in 1 year, showing incredible healing right there. Now I sent this, I showed this case to a periodontist who really wanted to extract the tooth, and he said that I would still take the tooth out. And I was like, why? He said, well, you're not going to be able to upright the tooth, and it's going to have a perio pocket there because of that plaque trap. And I understood where he was coming from, but what he overlooked is the ability for healing to take place if the etiology is removed. And that's the point. The patient did not want to save the tooth. They wanted to save the tooth. They did not want to have an extraction. And the patient can theoretically get orthodontic treatment and get this tooth uprighted and get it restored. Will restoration of this tooth in this area would be a challenge? Sure. But again, this is what the patient wanted. What is this? It shows up in your office. Think about, what is this? You guys are very smart. I can hear somebody say, "That's a tongue ring, Dr. Short," and that's exactly what it is. That's a tongue ring. So I just thought that was kind of interesting there. Tooth number 30. You got a crown, previous root canal, got a huge blown out area in the furcation. Here, minimum mobility, no significant probing. As a periodontist, probably what would you do? Extract it. Tooth is cracked, take it out and do an implant, possible. Patient didn't want to take the tooth out. So what do you think that could be causing this? The root canal don't look too bad, but they could be another canal, or they could be a lateral canal that could be actually not have been cleaned out, could not have been disinfected, that could have been causing that furcal area as well. So what we did, we took it apart, put calcium hydroxide in there and packed it in. And you see we got a little puff of calcium hydroxide in there. So this tooth either had a lateral canal or possibly even a subpulpal floor canal, which Dr. Obturated out of UPenn wrote a lot of papers about these subpulpal floor canals that could contribute to this furcal area of infection. So we completed the case, brought the patient back in 6 months, and my, look at that healing. And the furcation, and also at the distal root. Marvelous healing. And this is with no MTA. Another case, tooth number 30. You have a molar, the molar here, crown, a little ill-fitting, post root canal filling material looks pretty weak, probably left missed canal, large area of infection there. So we go in, we take everything apart, we use calcium hydroxide, we locate another canal, we obturate it. Before and after 1 year recall, large lesion, nice healing after a year. Am I still thrilled with the crown fit? No, I'm not. But again, I'm not the restoring doctor. And again, I just want to encourage you guys that the only way root canal success can stay at the highest level is that you have to restore these cases at the highest level. Root canal on 13 and retreatment on 14. This is a 2-year recall. Retreatment here, they actually missed an MV2 here. So we're able to retreat it and get that area to heal up. And tooth number 13, we don't see this too often, was a trifurcated premolar, and 3 canals in there. Tooth number 15, this is another one of those paste and silver point cases. So this patient came in also from Europe, and there was complaining, having some issues on this tooth. And here's a silver point here, and this is some paste material and the mesiobuccal and palatal canals. So using a microscope, we opened it up, cleaned everything out, put calcium hydroxide here, and we did locate an MB2, and it was able to save the tooth for the patient. So this is before and after. It's another case, tooth number 3. This is a crown. It has a screw post. By the way, I hope none of you guys are still using screw posts. We have so many other better posts out there that's available. I prefer parallel sided post. They have fiber post out there. Anything that will keep from putting lateral pressure on the root is great. So anyway, this case has a large area of infection here. I was concerned that the tooth was cracked. I told the patient, but she wanted to save the tooth. So we went in there, we took everything apart, we placed calcium hydroxide. I was a little happy with it. You can see I kind of got it all up in that area, but we know that calcium hydroxide is going to resorb. So we finished the case after we found an MB2. And this is a 6-month recall with really nice healing. So the patient was happy, and I was happy for the patient as well, that they were able to keep the tooth and also keep the same crown. So this is another case, tooth number 3, with a sinus tract there and overfilled on the mesial buccal. So we can see this is the overfill here, sinus tract here. I was trying to trace it, I couldn't trace it all the way, so we decided to retreat the case. We opened it up, we placed calcium hydroxide. I was trying to retrieve the gutta-percha. I couldn't, actually pushed it out a little bit more. I showed this case to some of my colleagues, and they said, Dr. Short, once you get done with the case, you really need to flap it and you need to do an apical on the mesial buccal root. And I'm like, well, why should I do an apical if gutta-percha is sterile? And that's not the etiology, so I would be doing a surgery on this patient for nothing. Now, if the area does not heal, I'll bring the patient back in 6 months to a year. If they don't heal, they still having issues, then surgery definitely will be an option. So I decided to leave it and see what happened. So we brought the patient back in 6 months. Remarkable healing, sinus tract went away, and you can still see the gutta-percha. Now, at this point, will I still go in there and do an apical on that just to remove the gutta-percha? No. Just watch it. The patient have problems, we can address it at that time, and as the patient continues to get her regular routine care by you, the general dentist, is something that you would just kind of keep your eye out on. So this is another case, tooth number 30. This patient came and she had a lot of pain, and she was leaving the country in 2 days. Even though she's smiling here, she was not very happy when I showed her what was going on x-ray. So here it is, we have a crown, root canal filling material overfilled on the distal, grossly overfilled almost into the inferior velar canal on the mesial. So we said, okay, well, we'll try to retreat this case. Hopefully we can retrieve this overfilled material and get a decent result. So we retreated it, and we found more than we thought. So not only that there was overfilled thermofill here, and this is what thermofill looks like. That's stripped from the gutta-percha. There's a separated file that we were able to get out, and also these are other remnants of the thermofill that was actually overfilled. So this is what it looks like when we took it all apart, and this is what it looks like when we completed the case. So we did this in one visit, a one-visit retreatment. The patient was very, very, very grateful, very happy. So at the end of the day, it's very important for you to give patients all options so that they can make an informed decision, because that's what it's all about. It's about giving the patients all the options so that they can make an informed decision. And that's one reason why I'm taking time to give you guys this presentation on retreatments, because frankly, some general dentists don't even know that we can actually treat or retreat some of these cases and still give the patient a pretty high success rate and help them to keep the tooth. And I understand that implants are out. I understand that everybody want to do implants, and there is a place for implants, but however, there's nothing out there that's going to be able to replace the natural tooth that you were born with. So, doctor, I have a question for you. What would you want? Would you want your natural tooth or an implant? So if it was your tooth, what would you want? Would you want this? I know you guys looking at this picture and saying, oh my God, I would want this if I was the one that would be receiving payment. So, because this would be very expensive. However, I think this is, and you would agree, that this is overkill. And trust me, I'm not saying that there's not a place for implants. There are places for implants. Personally, I usually like to retreat the case. If the patient does not heal, I really push an implant, basically because the success rate of an implant runs about 90–95%, which is the same success on average as initial root canal treatment versus surgery, where you can get anywhere from 40% up to 90%, but really an average surgery, you're probably looking at about 70%. So if the patient's already invested time and money inside of this tooth, wouldn't you want to give them the highest success rate? Yes, and we know that it is more expensive, but if they invest more money into a surgery and it still don't work out, they could have used that money to go towards an implant. Now, am I saying not to do surgery? No, I'm not saying that. But from my experience and years of teaching, what I've usually seen, if a retreatment, if it's done adequately and properly, if the patient does not heal, most of the time it's a crack. Unless it is a non-odontogenic issue, cyst, tumor, cancer, something, a true cyst, something like that. So just want to basically use your best judgments and look at it from your perspective. If it was you, what would you do? Thank you very much for your time. My office again is Apex Endodontics PC. Getting to the root of your problem is our slogan. We can be reached at www.apexendodontics.net. My phone number is 678-503-0790. I can be reached at dr.short@yahoo.com. In addition, if you want to get some more information about my treatment and how I treat patients, and even some more lecture material, you can actually Google me. I have a series of lectures out on the internet. Also, I have some web-based information that's out there where you can actually listen to, or you can actually watch some of the videos. So thank you for your time. Thank you for you devoting your attention to my presentation. Have a good one. Thanks again. Bye-bye.